My name is Katie Grogan, and it's my pleasure to welcome you to the 8th lecture in our series, Advancing Health Equity with Medical Humanities. This series was developed in partnership with New York University, the NYU Grossman School of Medicine, and the Arnold P. Gold Foundation. Our initiative is part of the Foundation's Gold Human Insights webinar series, and we want to express our deepest gratitude to the Gold Foundation for their support and collaboration on this project. I want to acknowledge my partners in the development of this series, Dr. Kim Adams, who is the Humanities in the World postdoc at the Penn State Humanities Institute, where her work focuses on public humanities and medical humanities, as well as Sharanik Bosu, who's a PhD candidate in English at NYU, where he focuses on economic thought, literary rhetoric, and public humanities. We're absolutely thrilled to have with us tonight Drs. Richard Greene and Christian Torres. Dr. Greene is Associate Professor of Medicine at NYU Grossman School of Medicine, where he serves as Faculty Director of Health Disparities Education through the Office of Diversity Affairs. He's also Program Director for the Internal Medicine Primary Care Residency, where he presents on various topics, including LGBTQ plus health disparities, and is also Medical Director for the Pride Health Center at Bellevue Hospital. Dr. Torres is Clinical Assistant Professor of Medicine at NYU Grossman School of Medicine and practices primary care and hospital medicine at Bellevue. He's also Director of Diversity Training and House Staff Mentorship within the Office of Diversity Affairs. In tonight's lecture, entitled As Seen Through a Lens, LGBTQ plus Health and the Media, Drs. Greene and Torres will weave together the histories of LGBTQ health and its coverage in the news media. A few quick logistical notes. We're going to ask that folks kindly keep their mics off. Please put your questions in the chat, which we'll be monitoring, and Sharanik will read them aloud during the Q&A portion. Finally, we're going to drop a link in the chat to a very brief survey. We'd appreciate if everyone could take a few moments to give us their feedback. And this survey is a necessary step for anyone who's claiming CME credit tonight. So when you see that, if you want to just pop it open in another tab, that would be great so you don't lose it. And then lastly, unfortunately, I have to hop off this call just before the hour is up. So I want to give a very quick plug for our next and final webinar in this series. We'll be back next month on December 14th for a roundtable discussion on the topic of diversity and equity in clinical trials, featuring Drs. Arthur Kaplan, Aisha Langford, David Oshinsky, and Julie Sawash. As always, CME credit will be available, but it's free and open to all. So we hope to see you then. Once again, thank you all so much for joining us, and I'm going to turn it over to Sharanik.
Thank you so much, Katie. Before we go over to Christian and Richard, I just have two very small things, logistical things to show you. And after these very short interludes, we will go over to Richard and Christian. So please bear with me.
The best healthcare is compassionate, collaborative, and scientifically excellent. Thank you for being on this mission with us to ensure humanism in healthcare for all. This is a Gold Human Insight webinar produced by the Gold Foundation and its partners.
Hello, I'm Pia Pine-Miller, Senior Director of Strategy and Business Development for the Gold Foundation. The Gold Foundation created the Gold Human Insight webinar series to bring inspirational live and pre-recorded webinars to healthcare professionals and learners. Our 2022 theme is Renewing Our Commitment to Humanism. With the myriad of challenges facing healthcare systems today, including patient disconnection, clinician burnout, and even more challenges highlighted during this time of the syndemic of COVID and social justice issues, the Gold Foundation's vision of a better future remains more urgent than ever. Today's Gold Human Insight webinar is one in a series that is part of a special collaboration with NYU School of Medicine, which is an institution that is a member of the Gold Partners Council, a group of medical schools, hospitals, and healthcare systems that are leaders in humanism in healthcare. Thank you to our presenters and our audience for everything that you do.
Today's lecture is part of a larger series on advancing healthcare equity with medical humanities.
These slides provide a description of the larger series and accreditation information from the NYU CME office. They are required for attendees seeking CME credit and are available to all who are interested through the Gold Foundation website.
Excellent. Christian and Richard, the floor is yours.
Excellent. Thank you so much. And thank you everyone for being here. We're very excited to get to talk to you tonight about LGBTQ health and the media. And I'm thrilled to be here with my friend and colleague, Christian Torres. So hopefully this will be a fun presentation and then a good conversation afterwards. And we look forward to hearing from you. We wanted to start off by first saying thank you to the Gold Foundation for sponsoring this webinar and for inviting us to come and speak, and the collaborators, NYU and NYU Grossman School of Medicine. It's notable to be having this conversation after this weekend's tragic events in Colorado. For those of you who may have not heard, although if you're here, I'm assuming that you have some social media that sort of shared this story with you. 5 people were killed and 18 were injured by a gunman who entered an LGBTQ nightclub, Club Q, in Colorado. And I think it's really important for us to acknowledge this. And so in keeping with our theme, we have an article from Them magazine, The Headline, which is an LGBTQ magazine for the community. We have a tweet from Dr. Dimitri Daskalakis about this, who said, and I really appreciate this hashtag, hate is a public health emergency. Gun violence is also a public health emergency. And that this happened on Transgender Day of Remembrance, which was an event that was happening at the club, is incredibly important. And I included one more slide. This was from the Williams Institute, which collects data about LGBTQ people. And is about the disproportionate amount of violence that LGBTQ people are subjected to. And Trans Day of Remembrance, if you're not familiar with the holiday, is a day for us to take a moment to remember the trans folks who were lost before their time. Every year, there's a count of how many trans people we know of who are simply just killed for being trans in our culture. And as of now, I think the count is up to 32 in this year alone. And so to be giving this talk after this tragedy is really important, I think, for both of us and for all of us to engage in this conversation with you. So thank you for being here. And we're eager to talk more about what we think is a really important issue. So I'll introduce myself first, and then I'll hand the floor over to Dr. Torres. My name is Richard Greene. You heard a little bit about me. I work in the Pride Health Center at Bellevue Hospital, so I take care of uninsured and underinsured folks in the LGBTQ community. I've been doing that for about 20 years now, in different ways and in different locations. I'm the Director of Health Equity Education at the Med School in the Office of Diversity Affairs, so I oversee inclusion of topics about health equity, including anti-racism, and also LGBTQ health throughout our curriculum, both in the med school and also in the internal medicine residency program. My pronouns are he and him, and I'll hand it over to Dr. Torres.
Thank you, Richard. My name again is Christian Torres. My pronouns are he, him. And I work with Richard both in our Office of Diversity Affairs at NYU Grossman as the Director of Diversity Training and Health Staff Mentoring. Part of what I'm also bringing to this talk, other than working as well at Bellevue Hospital as a primary care doctor and hospitalist, is a previous life actually in journalism, in which I was a health reporter for publications including the Washington Post, Politico, and others. And so what I'm hoping to do tonight, along with Richard, is provide to you some insight into not only LGBTQ healthcare and the care that we provide, but also the way the news media functions and what we provide and how we influence that as well. Next slide, please. So our objectives today are basically threefold. First, we want to provide you all with a sense of the history of LGBTQ+ health, in particular, the role of the medical community, which I recognize many of us on this session are a part of. Second, we're going to be looking at the role of the news media, non-medical news media in that health system, in particular, how it has covered HIV/AIDS and health disparities generally within the LGBTQ community. Lastly, what we're hoping is that by reviewing each of those and their influence on one another, you have a sense of the way in which these two institutions really impact one another and impact the care of the LGBTQ community. Next slide. To help with that last point, I want to present you all with an overall framework. So when we approach health, we often think of an individual's health being affected by many factors that live outside of the clinic room that we're in or the hospital bed that we're working in. So that might include things like insurance status, access to food, access to healthy food, access to medicines, and so forth. We often refer to these as social determinants of health. Today, however, we're going to be focusing on one particular social determinant of health, and one that you probably don't think about very often, which is the news media. To be clear, we're also going to be focusing in particular on one segment of the media, which is the lay news media, which I want to differentiate from entertainment media like TV, movies, etc., and from professional media like scientific journals. I am going to include some mentions of social media, but mainly how that relates to the way the lay news media utilizes that social media when it's sharing its publications and so forth. With that in mind, we're going to review how the media contributes to the health of our society through a dynamic interplay with medical providers and patients themselves. So for example, patients and providers, we both get our news, or at least our general world news, from the same sources. That includes the health news that we receive from those same sources, but the way that we receive that information and the way we understand that information can differ based on our background and our educational experiences. For our patients in particular who don't have the same medical understanding that we may have, their idea and their perception of certain health issues, in particular those that affect the LGBTQ community, depends very much so on what they see in the news media. For many of our patients, they hear from news publications and news organizations much more than they hear from an individual provider. And so it's very important that we recognize that the way that those issues are framed by the news media very much affect how they are perceived within the community and outside of it. Next slide. And with that, I'll turn it over to Richard to talk a bit more about that framing of LGBTQ identity.
So this may be really basic to some of the folks in the room if you are a part of the community or doing work in the community, but I feel like it's a place that we have to start, and it'll be relevant later to when we talk a little bit more about how we think in healthcare about LGBTQ health, and also then how we think about how that's presented in the media. And so I want to first differentiate sex and gender, sex being something that we often think of as biologic and gender being an identity that people hold. Both of these are socially constructed. I feel like people are getting to be more and more comfortable with the idea of gender identity being socially constructed. But I wanted to start by talking a little bit about sex. And sex is something that we often think of in context of a binary. When a baby is born, we often ask the question, oh, is it a boy or a girl, right? Gender reveal parties have been taking down forests in California for like years now, it feels like. And so before we get too much into that, I want to make sure that we're clear that sex is also socially constructed. And so there are really 7 characteristics that doctors think about when they assign a baby a sex when it's born. We think about what chromosomes the baby has if we have access to that information, so XX or XY. We know that there are variations in those chromosomes and that there are other variations outside of XX and XY. We look at a baby's gonads. So do they have ovaries? Do they have testes? Do they have undifferentiated gonads? How did their genitalia form? And what do we consider normal or not normal? And who dictates that? What internal sex organs do people have? So do people have uteruses? Do they have prostates? We think about what hormones they produce on their own. We think about how their body responds to those hormones on their own and how that might impact their development. And then we think about what kind of puberty they might have as they develop secondary sex characteristics if left unaided. And we know that some babies are born not infrequently with differences of sex development. And so we know that any of these characteristics could exist on a spectrum. Some of them have medical consequences that might need to be assisted. Some of them don't. Some of them used to be fixed for reasons that were social, and we're stopping doing that as much in the healthcare profession. Gender is an identity that we then hold, and we socially construct this based on different characteristics that are assigned to different genders. So there are masculine traits and feminine traits. There are some traits that have no gender associated with them. So for example, if I have green eyes, that's not a gendered characteristic. We haven't assigned that something, but my bald head usually indicates a masculine trait, right? And so everyone has some combination of different traits. This is how we sort of see and perceive them. The media might present these things very differently. I think it's also important to remember that while people might have a gender identity that's different than their sex assigned at birth, so for trans and non-binary people, we have to identify that not everyone presents their gender in a way that is consistent with their identity, particularly as they access healthcare. Healthcare can be a really scary place to be if you don't think you're going to be accepted. And so a lot of my patients will show up dressed differently than their gender identity because they're afraid of how they will be perceived or taken care of. And so for that reason, as people move through the world, and face the real threat of violence, people might make different choices. And so we can't make assumptions about what people's identities are. And then last but not least, sexuality exists in a completely different plane than gender and sex. Anyone of any gender can be attracted to anyone else of any gender. But sexuality itself exists in multiple different domains also. So not everyone who identifies as a gay man, for example, is having anal sex. And so we often break that down in terms of what behaviors are people engaging in, who are people attracted to, and then how do they identify in terms of their sexuality? And there are many different ways that people can identify. The media loves to play around with these identities and sort of vilify some and validate others. So why is this an important topic? This is just a very brief slide to tell you some of the numbers. So it's estimated that about 14.5 million people identify as gay, lesbian, bisexual, or transgender. That's about 4.5% of the population. About 1.4 million people, or 0.6, identify as trans. And that depends how you count and who you've asked and where those numbers come from. Those numbers come from the Williams Institute at the last count. And then it's estimated that about 36 million people, about 11% of the population, have engaged in some form of same-sex sexual behavior since puberty. We know these numbers are increasing among youth as the stigma about LGBTQ identities decreases, and we're starting to see much more. And so we're going to need to be prepared in healthcare to be able to take care of people regardless of their identity. I also want to differentiate. There are a lot of letters, and I often hear that. And while the LGBTQIA+ community is often sort of put under one umbrella, each of these letters represents very different identities, and even within each letter. So there is incredible diversity among who identifies as a lesbian and what that means for them. And so no identity is a monolith, but within the community, certainly because of different behaviors or different attractions, you're going to find very different health issues among different people. So we are sort of lumped together, and there are many similarities in terms of the kinds of stressors that we face, but also every identity is going to be different, and it's going to mean different things to different people. When you put people's gender and sexuality together with their other identities, including racial or ethnic identities, including religious identities, including disability or other intersectional identities, you really can't tease these out. And so people who have two minoritized identities might experience a deepening of their experience of oppression than they would with just one of those identities. And people who have simultaneous privilege and oppression might experience a real tension around those two things, depending on their identities. This is a photo of Professor Kimberly Crenshaw, who's a law professor who first identified intersectionality theory. And so we credit her with that work. And then just a very simplified model of where health disparities then come from is that as we hold all of these different identities and as society responds to our identities, we respond to multiple kinds of stigma. The first kind is the messages that we receive and internalize are intrapersonal stigma. So what are the messages that I've internalized that might prevent me from wanting to go to see a healthcare provider because I'm afraid of what might happen to me, right? Maybe nobody did or said anything that was really inappropriate in this moment, but I've internalized those messages. That combines with the interpersonal stigma. So who says what to me on the phone? If I identify as a trans man and someone calls me ma'am, then I might not want to go and make an appointment with that doctor. And that's a form of interpersonal stigma. And then the structural stigma are what are the things that exist in systems and structures and policies that challenge our patients who are going to be accessing care. And so do your forms include the patients who are coming to see you, or do they have binary gender fields? Does it say male and female and not really ask why they're, or not really inform you about why we're asking those questions? So when you exist with these three kinds of stigma, we know that that causes minority stress, which happens to any person who holds a minoritized identity in our society, can lead to increased rates of anxiety and depression, and also worsen health disparities. We know that when those health disparities are worsened, they take the form of mood issues, depression, anxiety, sometimes PTSD when people have really faced a lot of trauma in the past. But also then people who are facing that level of stigma will often very frequently engage in increased risk-taking behaviors to cope with some of the stress that they're facing. So increased rates of smoking, alcohol use, substance use, and many other kinds of, and even high-risk sex, and we'll be talking about that in just a minute. So just to sort of lay out that model as we go into talking about some of the historical events that have happened in the LGBTQ community. This is certainly not a comprehensive timeline. We put together some of the important events that have happened that have impacted LGBTQ health, starting back in 1969 with the Stonewall riots. That is not the first time LGBT health was impacted by things that happened in history, but it's one of the most known. It was a riot that happened when there was violence at a gay bar. Police were coming in to arrest people at a gay bar. It was illegal to congregate. And so they were arresting people at the bar. The patrons decided they weren't going to take it anymore. Marsha P. Johnson was thought to have thrown the first brick at Stonewall. Marsha P. Johnson is a Black trans woman. Similar riots were happening on the West Coast as well at the same time. Until 1973, homosexuality was considered a paraphilia in the Diagnostic and Statistical Manual of Psychiatry. And so any psychiatrist who was seeing someone who identified as gay or lesbian was basically told that that was a pathology that they had to treat. In 1980, we saw the first case of AIDS in the healthcare system. It was first identified as GRID, or gay-related immunodeficiency. That's how it was publicized in the media. By the 1990s, lesbian, bisexual, and queer women were identifying that their health needs weren't being adequately addressed by the healthcare system, and founded an organization called the Modner Project, which became a primary caretaker for LBQ women. By 1995, we had the introduction of effective therapy for HIV, which involved usually taking 3 medications. And so it became more controllable for the first time and was not something that was quite so stigmatized, but stigma still remains. In 2004, the American Psychological Association discredited conversion therapy as a way to stop people from being quote unquote homosexual. And then in 2011, the Institute of Medicine, which is now the National Academy of Science, put together their first report on LGBT health. There was a 660-something page document, and I will summarize it for you. It basically said, we need more research because we really don't know what we're doing. They recently released another report that has a lot more data in it. In 2013, there was an update to the Diagnostic and Statistical Manual of Psychiatry, the 5th version, which changed gender identity disorder, a very stigmatizing name for the dysphoria that trans people experience, to gender dysphoria. Still not a perfect term and widely controversial in the community, but a little bit less stigmatizing. In 2014, the CDC released guidelines for pre-exposure prophylaxis for HIV, and we'll talk a little bit more about how that's been received as we get there. And then in 2015, marriage equality was upheld. And for the first time in history, marriages among LGBTQ people were considered to be, were being honored. And imagine what that means when you're seeking healthcare about what kind of decisions your partner can make for you, how and when people can speak for you. There have been many cases in the past of people whose partners were barred from seeing them at the moments of their death because they were not quote unquote married. And so that has a lot of impact on the psyche of the people in the community trying to engage with healthcare. So that's a very brief overview of health issues in the LGBTQ community. And we're going to transition, and Dr. Torres is going to take over and talk a little bit more about then how this has been presented in the media.
Thank you, Richard. Next slide, please.
Sorry, taking a sip of Diet Coke.
No worries. So much like Richard, I wanted to present you all with a parallel timeline in a way, but one that certainly affects the other. And this is focused more on LGBTQ news coverage and media coverage. And so I'm going to start in 1967, actually before the Stonewall riots, with The Advocate first being published. So The Advocate is the oldest LGBTQ plus publication in the United States. It's still in existence, albeit publishing less frequently, with about 6 issues a year now, I believe. It really was important as a first queer-focused publication to elevate stories within this community and eventually have them become part of the mainstream news media as well. Next up, I'll go to 1980 when the Human Rights Campaign was founded. HRC, as it's well known, was originally started as a primarily political organization in terms of supporting political candidates, but it has evolved over time and has been really vital in terms of the marriage equality being upheld by the Supreme Court and many other issues. And it's also a very major advocate among news media organizations. Next, I want to mention the first New York Times article that referenced HIV, which was in July of 1981. I'll circle back to that in a bit. But next, I'll go to GLAAD in 1985, the Gay and Lesbian Alliance Against Defamation. So this organization, which many of you may now know in terms of its reports on entertainment and lay news media, was actually originally founded by a group of journalists. And it was founded in response to some of the New York Post's news coverage of HIV at the time and how it was very stigmatizing and damaging to the LGBTQ community. They gathered together, formed GLAAD, and is now a major player in this space, both providing best practices and also recommendations to lay news media in terms of how they cover LGBTQ issues. Next, I'll mention And the Band Played On, a book by Randy Schultz that was published in 1987. I'll also circle back to this in a moment and go back to another organization, the NLGJA, which is the Association of LGBTQ plus Journalists. This was founded in 1990 and was important not just in terms of elevating LGBTQ issues and ensuring that there were best practices shared within the journalist community, but also in terms of progressing diversity and inclusion among journalists themselves. As I think we're all very well aware of, if you don't include people who hold these backgrounds and can share these stories and understand these stories, it's difficult to provide quality coverage of those same stories as well. I next want to jump forward more than a decade to Twitter, which was founded in 2006. I said that I wouldn't focus too much on social media, but I think it's important that we acknowledge this event. Regardless of your feelings about Twitter today, I think it's important that we recognize that Twitter has had a tremendous impact, not just on the lay news media, but the way that it has covered certain events, including two of the following ones that I mentioned here, much like Richard, marriage equality being upheld, but also then COVID and monkeypox most recently. Twitter has been a major source for not just patients, but also providers in terms of their information sharing. And it's also made the media landscape much more challenging for mainstream, accurate news media to share those same stories and ensure that the information got out there. Lastly, I want to mention something from 2017, which is the Associated Press Style Book. And so the AP Style Book might not be something that you're familiar with, but it's something that's bedrock to a lot of journalism and to a lot of journalists. It's very important in terms of delineating what language we use, what terms we use in whether it's written communication or radio communication, whatever it may be. And in 2017, the AP Style Book, which is kind of the gold standard for how these terms are utilized, first acknowledged that LGBTQ was an acceptable reference when referring to the gay or lesbian or previously any other combination of that community. And so that was a major advancement in terms of acknowledging that this is a wide, diverse community on its own. They also at that time acknowledged and deemed acceptable the use of the word they when referring to an individual by pronouns, rather than just he, him, or she, hers. Next slide, please. So I brought up that last point about terminology and the AP Style Book being very important because I think that that terminology is so important to the quality of the coverage that the news media can provide when it comes to health. And it's not just about quality, it's also about the quantity of that news coverage, as this graphic delineates for you as well. So this framework here really gives a sense of how the news media is important in terms of both reducing and potentially worsening the health disparities that we see within the LGBTQ community and others. So for example, something that Richard mentioned before, when we saw the marriage equality debate several years ago, there were several news stories about it. And among those news stories, many took the angle of talking about how people in this community were unable to visit their partners in the hospital, were unable to provide insurance coverage for their partners. And those news stories had a lot of impact because they showed a very prime example of why marriage equality mattered. And they really humanized the experience, they personalized it, they provided a story for people to anchor on. And I would say that that argument was one of the key ones in terms of leading to marriage equality's success. At the same time, the news media has made missteps. And so in another example I'll bring up, the news media often highlights the prevalence of sexually transmitted infections and other things within the LGBTQ community. And while the intention may be good there, while they are trying to highlight spread of gonorrhea and other things, for example, when they do that, they may unintentionally highlight and reinforce stereotypes about sexual promiscuity and other things within the same community. And when you do that, when you reinforce stigma and when you reinforce those bad stereotypes, you can lead to fear of people getting tested, and you can lead to fear of people getting the treatment and the medical care that they deserve. Next slide. And so with that, I think we're going to start with a prime example of all of this, which is HIV, and I'll turn it back over to Richard.
Sure, thanks. So this is just a very brief representation of gay, bisexual, and queer men's health, and we're going to use 3 different sort of stories to illustrate how LGBTQ health is being portrayed in the media and some of the common pitfalls that we see. So I'm going to give a brief overview about things that we think of clinically when we're taking care of gay, bisexual, and queer men. It is challenging, and we still start off with thinking about HIV. We think about both treatment and prevention, and the way we take care of it has evolved quite a bit over the last few years. We'll get into that in just a few minutes. We do think about sexually transmitted infections. And to add to what Dr. Torres was saying before, right? So the media can first stigmatize people by talking about sexual promiscuity, but also can lead with the underlying assumption that having more sex is bad. That's a socially driven message. Is that true? Is it real? Why is that a thing? There are moral values around that, but it's not the media's job to necessarily uphold them. So we know how those images get into the media. And so as we think about this, as a healthcare provider, I have no value judgment about how much or how little sex someone is having. That's not for me to decide. It's my job to help people be healthy as long as they're having sex that is healthy and consensual. It's my job to be supportive and make sure that their health is taken care of. We mentioned earlier that folks who face a lot of minority stress can also engage in substance use, which can be harmful to people's health, and we can have conversations about that. We can do it in a reasonable and meaningful way that engages with harm reduction approaches rather than stigmatizing people for the choices that they're making. And we can engage with people around their mental health. And this is all in the background of good general primary care, where we do screening for chronic diseases, where we offer people vaccines, all of the things that we would do for anyone else. But these are things that, as a healthcare provider for gay, bisexual, and queer men, I want to make sure are in my armamentarium and that I know to ask people about.
So in June 1981, the CDC first reported on what was previously a very rare pneumonia due to pneumocystis among a group of previously healthy gay men. This came through the Morbidity Mortality Weekly Report, MMWR, from the CDC, which likely many of you are already familiar with. This is, of course, a mainly provider-facing communication, not something that necessarily went out to the general public. As we soon learned, these cases of pneumocystis were related to a new virus that was affecting the immune system. And in yet another example of the importance of language and how language matters to public perception, this illness was initially called GRID, or gay-related immune deficiency. It was only later that it became known as HIV and AIDS. Next slide, please. So it was about a month after that MMWR report that we first saw the lay news media mentioning an HIV-related disease. This was that July 1981 New York Times article that I mentioned before, which first talked about cases of Kaposi sarcoma, and also a previously rare disease that was seen among a group of homosexual men, as mentioned in the headline. In the coming months, as members of the scientific community were starting to engage with this and look into this and take action, it was sadly the news media that was often lagging behind. And so they were lagging behind not just in quantity of coverage, but also the quality of coverage, with many articles in the New York Times and other publications focusing on this being a disease among the gay community and not focusing on and not including its spread among other communities as well. They were also reinforcing stigma within the LGBTQ community and elevating really fear among members of that community and among members outside of that community. Gradually, the quantity and quality of coverage did pick up, and I think we can thank people like Randy Schultz for this. So as I mentioned before, Randy Schultz was a journalist who wrote this book called And the Band Played On, which really spotlighted HIV/AIDS and what was happening within both the LGBTQ community and the medical community. So
Oop, Christian, I think you froze. We're going to give him 1 second to come back.
San Francisco. As I mentioned before, the book reviews the evolution of HIV in the gay community and the medical community, but Schultz also really calls out government officials, politicians, and the media themselves for the way that they cover this as a quote unquote gay disease. One of the things that Randy Schultz particularly notes in the book, and that I want to bring up now, is the way that the media didn't really pay attention to HIV/AIDS, at least in a humanistic way, until it was really individual celebrities who disclosed their HIV status, including people like Rock Hudson, Magic Johnson, and others. Next slide. So you can see here, for example, the uptick in coverage that came with those two celebrities sharing their HIV status in 1985 and 1991. This is a 2002 Kaiser Family Foundation report that basically looked at the number of news stories on HIV and AIDS, the dotted line that you can see there, versus the cumulative number of cases, that large gray wave that you see going up. This, you can see in that HIV coverage significantly picked up as those celebrities disclosed their status, but soon after, it downtrended, despite the fact that there were several events further along this graph related to HIV management and treatment. This graph ends in 2002. There was a more recent analysis, again by the Kaiser Family Foundation in 2008, that looked at how much HIV/AIDS coverage was part of overall news coverage. And HIV/AIDS only accounted for 2.2% of all health news coverage, which was itself just 4% of the entirety of news coverage. So that gives you a sense of how little we talk about HIV/AIDS in the news media, despite significant advances in recent years, including with PrEP and other HIV management. For more on that, I'll turn it back to Richard.
And we'll talk about that in just one second. The one other thing I wanted to point out about this slide is it's also about which celebrities the news media chooses and what stories they choose to frame. And so if you look at this timeline, what you'll see, and I think a bit older than many of the people on this webinar, but the story of Rock Hudson was a story about a celebrity who was shamed as he came out of the closet and was revealed to have AIDS. And that was the only story that you'll see on here of a gay man who had HIV, even though that was largely the profile of people who had HIV in the healthcare system. The next story, which was in response to some activism, was a story of Ryan White, a child who died of AIDS. And that story was meant to evoke sympathy for people who had HIV and AIDS. But to do that, he was a white, cisgender, thought to be straight child. And that made him someone that people would care about, right? That's how the media sort of framed the story. And subsequently, the next two people who were focused on were Magic Johnson and Arthur Ashe, two cisgender Black men who were sports celebrities. And so you could see the media really makes very clear choices about the kinds of information that we get. And so here we are, it's 2022. We now talk about HIV in context of status neutral delivery. We think about it in context of risk, not who has the virus and who doesn't. We think about it in terms of if you have risk for contracting or passing on HIV, it is for us to make sure that you are engaged in care and that you feel supported in the care that you're getting. And if you have risk for HIV, that you're taking some kind of biomedical prevention, whether that's a pill that you take daily, or whether that's an injection that you take periodically, or whether that's using condoms when you have sex. None of this says anything about having less sex or having less sex with people who are identified as LGBTQ, right? And so I think it's a very different model now. We also know that for people who have HIV, different than in the past, if you have HIV and your viral load is well controlled, it is virtually impossible for you to pass on HIV to your partner. And so engagement in care is really the thing that we care the most about, though the stigma lives on, even within the LGBTQ community, about people who have HIV, that they may infect other people, even though that is incredibly unlikely. So I want to contrast that story a little bit with what happened with monkeypox recently. This is something that happened. There is a move towards changing the name of monkeypox. I'm using that as the lay term that you've probably mostly heard of, but to move away from what is a potentially stigmatizing name towards MPV. So you'll hear me reference that for the rest of the talk. And in April of 2022, an outbreak of MPV that was happening in different parts of Africa started to make their way to the United States. There was lots of consternation. We hadn't seen this in the United States for a while. Notably, we didn't offer aid when it was going on in Africa. So there were smallpox vaccines that existed, and they were not made available globally to try to prevent the spread that could have been prevented. But as this started to happen, many of you know that Pride happens in June. Those of us who exist in the community saw this coming and said, Pride is going to be a disaster. Dr. Torres and I work in New York City. Pride is a big event here. We know that we get people from all over the world. So we knew that we would have people traveling. We knew that things were going to start to spread, and we knew that there was a vaccine. And the problem was there wasn't enough of a vaccine. And so the news media coverage started to cover it, but in very small ways. It was very hard to mobilize a response. People within the response used social media to start to activate the community. And it became really hard for people to get vaccines. And so I want to highlight some of the articles that started to come out in and around that time. And so early on, there was a real tension in the media about whether they were going to name that the gay community was largely the community that was being affected by monkeypox. Nobody wanted to stigmatize anyone. And also it was important to get the information out. And that tension was sort of like rode. There were challenges about sort of the science and the lack of the vaccine that was published in the New York Times. But I want to highlight something about these pictures. And so these pictures to me are really interesting because monkeypox at the time was thought to be spread through skin-to-skin contact, but also potentially as an airborne infection. Public health officials didn't want folks to be inside and enclosed spaces too close together for too long. So lines were formed outside of public health spaces where vaccines were being offered. And because they were in public health spaces, people were taking pictures of the people waiting in line. At the time that this was going on, the only people who qualified for the vaccine for MPV were people who had had at least one or multiple anonymous sex partners in the past 2 weeks. So you can imagine that we now think we know a lot about the sexual history of the people in these pictures who could be identified. Now, we know within the community that that wasn't the case and that many people who perceived that they had high risk were going to get the vaccine. And so we do not genuinely know anything about these people's sexual history, but also there was tremendous fear in the community and it led to really uneven reporting in the press. Many of you will probably remember that.
So Richard makes a really great example here of how the framing and the actual presentation alone of a news article is really important to our public perception of monkeypox and other issues. And so one thing that I want to use to contrast with the HIV/AIDS crisis is the era of social media now. So I mentioned before Twitter, of course, and basically we have news media organizations and public health officials and others with expertise in this competing in an environment which there are non-experts, non-professionals also putting out this information. And so this analysis from earlier this year looked at the top 100 tweets related to monkeypox on a given day in May, which is right around when this pandemic began, and looked at them, and they found that a small fraction, just 8 out of the 100 tweets were from news media, and only 32 were from healthcare professionals. 60 were from informal individuals. More concerning, more than half were either non-verifiable information or misinformation entirely. And so serious information, quote unquote, was only about a quarter of those top tweets. So if you can think about our news environment and our information environment being heavily reliant on Twitter and similar organizations, we see how misunderstandings and myths and other things about monkeypox, including stigma, can easily spread. Next slide. Speaking of myths and misunderstandings, we'll turn it over to Richard to discuss more.
Yeah, so that was a story about sort of the interaction of health and the LGBTQ community and how the media really shapes how we frame and perceive those diseases and conditions. We're going to talk a little bit now about how the news media shapes public opinion about topics and how that bias can really lead to medical harm. So this is the cover of Time magazine from 2014 featuring Laverne Cox, who is one of my heroes. I just want to put that out there. I love her. TGD stands for transgender diverse individuals. And so this was a moment in time that we thought trans people were having their moment and were sort of going to come and finally be accepted by sort of the culture at large. Time magazine, one of the largest national publications, was talking about trans identities in a supportive way. And that felt like a really amazing thing. And it was the title of the article you can see is The Transgender Tipping Point. Now, as someone who is actively engaged in healthcare with trans and non-binary folks, we think about this in a lot of different ways. First, like I said, with gay, bisexual, and queer men, prevention and primary care for everyone, right? We think about vaccines, we think about screening, we think about chronic disease management. For trans and non-binary people, we have conversations about gender affirmation and what that means for people. Everyone's transition is different. And so that might involve hormones, it might not, it might involve surgeries, it might not, it might involve support if people are doing things like binding or altering their appearance in some way. All of these things are considered, though, to be essential care. We think a lot about mental health when we talk about trans people. One of the things that I am always sort of, that always challenges me is that when we talk about this in healthcare, we talk about issues of depression, anxiety, suicidality, which is very common among trans people. And we talk about that as though it's something intrinsic to trans identities. The truth is, it is not intrinsic to trans identities. People who have access to gender affirming care and supportive social structures who are trans or non-binary do not have increased rates of depression and suicidality. It is the existing in a world that does not accept you, the existing in a world that is a constant threat to you that leads to depression and anxiety and suicidal ideation. And so keep that in the back of your mind as we go on to talk about the way the media is framing issues around trans health these days. As healthcare providers, we also have the power to write letters for people to support their social or legal transition. So to keep people involved in jobs, to support people in challenging their health insurance, to get people's names on appropriate names onto their legal identification. It's really hard to travel or have identification that has a picture or a name that is different than the one that you use or that looks different than you. And so as healthcare providers, we can engage in all of this, and it's really not that hard, but people have a lot of thoughts and ideas. And so if you remember that gender is socially constructed, like we talked about earlier, the thoughts, ideas, and opinions that people in healthcare, that people outside of healthcare, that people in the press hold will make their way into some of the coverage. So this slide sort of references, this is from Reuters, this headline that says, as more transgender children seek medical care, families confront many unknowns. And it creates this idea, and you can see below it says, and this is from October, this is from last month. It says, but when families decide to take the medical route, they must make decisions about life-altering treatments that have little scientific evidence of their long-term safety and efficacy. And what they're talking about here is children taking hormone blockers. Largely, children are not being offered body-altering surgeries before they are at the age of consent. And so we're talking about puberty blockers. Puberty blockers are also something we use when we perceive that children will grow up to be short because we block puberty and allow their growth plates more time to grow. And so we've been using them for years, but the media is really uncomfortable with the idea of using them in context of a child who has a gender identity that's different than their sex assigned at birth. And so we get these really sensational headlines that foster the idea that this is unknown or not born in science. And so what we know from the data is we know that 50% of trans youth have either thought about or attempted suicide at some point in their lives. What we know about adolescents who attempt to commit suicide is they are disproportionately LGBTQ or trans and non-binary identified. And so we know that people are dying because they can't access the care that they need. Headlines like this say to parents who might encounter their child who has a gender identity that's different from their sex assigned at birth, that this is an unknown Wild West and might be harmful to their child where there is not otherwise harm. And that's not the decision balance that we're talking about. This is a tweet from Chase Strangio. Chase Strangio is a lawyer with the ACLU who is very active about advocating for trans youth to be able to access the care that they need. You know about all of the, there are so many bills now about trying to stop healthcare providers from affording care to trans and non-binary youth, even with the consent of their parents. It is really distracting. And I think this quote is really important from Twitter. I know we said we weren't going to do too much social media, but here we are. We have reached a very painful and depressing escalation in the legislative and non-legislative policy attacks on trans young people. What is perhaps the most disheartening is the lack of national attention and outrage from our supposed allies to meet the fixation from our opponents. And you'll see that we have not selected an overwhelming majority of our headlines from like Fox News or from known conservative, we have a couple, but from known conservative outlets, but from more what are considered to be more neutral outlets. And I'll hand it back over to Dr. Torres.
So speaking of those headlines, I'll share a couple just to show how, even, there are, of course, mainstream news organizations like Reuters and New York Times, as Richard just shared, and several examples that have made errors potentially in their framing of these issues. But there are, of course, also media organizations that are in a way trying to advance certain narratives that are harmful to the LGBTQ community. So to take an example from Fox News, just look at these two recent headlines, including the first one that references a report, which is really just an opinion piece if you want to look at the article yourself about teens expressing regret without real data, quantifiable evidence regarding it, even just using gender affirming care in quotation marks. The other about the Florida Medical Board's recent decision regarding gender affirming care with an immediate quote from the Surgeon General that's focusing on this as being a fight for kids and really is lacking the nuance of the discussion and the importance of this. Next slide.
So the last sort of note that we want to talk about here is what happens when there is no crisis, right? So trans folks have become a lightning rod for the media and they want to talk about that, or HIV and AIDS and monkeypox have been a very big sort of social topic. But there is one group that we haven't really talked about. There are many, but one of the groups within the LGBTQ community that we haven't really talked about is, what about lesbian, bisexual, and queer women? And so this is a group of people who also face significant health disparities. And as someone who takes care of them, I know and recognize where a lot of this comes from. And so outside of general primary care and chronic disease screening, we want to talk to lesbian, bisexual, and queer women about reproductive health. We know that there is a risk of delayed diagnosis of certain cancers because people have had bad experiences with healthcare and don't like coming in to get screened when they've had prior traumatic experiences, and also have significant mental health risks. And so there has not been a sort of crisis about lesbian, bisexual, and queer women's health, which is really important to note. And so it doesn't get a lot of media attention. And so where are lesbian, bisexual, and queer women and the people who love them finding out about the urgency to access healthcare that we believe there is? And so I think it's really important for us to also note the absence of news on particular communities. I also think it's really important to say, and I've been talking a lot about mental health challenges and substance use and all of these kinds of things. Whenever I talk about the LGBTQ community, I'm a proud member of the LGBTQ community. What it feels like being a part, and many of you may know this yourselves, but what it feels like being a part of this community is that there is incredible joy and incredible resilience within the community. And that what we're talking about when we talk about these sort of depressing statistics is about the interface with our society or with our culture or with healthcare specifically. Unwelcoming spaces are what leads to those health consequences. It's not about being a part of a community or associated with any identity. And so it's something that gives us great pride. And then I'll hand it back.
To finish today, I just wanted to bring us back to the framework that I initially shared. I hope by now that you have a sense of the influence the news media, medical providers, and patients have on one another when it comes to elevating and paying attention to LGBTQ+ health. I hope you also have gotten a sense for the pitfalls that we've seen in these many historical examples. And so whether it's a lack of quality coverage of HIV, the misframing of issues like gender affirming care, or the lack of awareness, the lack of coverage, and thus the invalidation of people's experiences, we see that there are many problems with our current news media and our own care from the medical community. So that really gives us an opportunity to do better. And so I think we as people, as part of the medical community, have an opportunity, for example, to think more about the way that we communicate with our patients and in terms of being inclusive in our communication as well. We can also advocate and work with the news media to pay attention to certain topics, and we can also provide that expertise. Meanwhile, we ourselves, we are still also media consumers, and we are ourselves patients at times. We can be selective and intentional with our news consumption. And so that includes being mindful of what you read, what you watch, what you listen to. It also means being mindful of what you share, whether that be on Twitter or other social media platforms. And lastly, I think it's important to acknowledge, it's important to be mindful of what you subscribe to, what you pay for, what you support in terms of good news coverage. And with that, next slide. We'd like to thank you all for joining us this evening. We'll be happy to take questions in a moment, but in case we don't have time, please feel free to reach out to us via the emails here. You can also follow us on our Twitters. Next slide. And we'd just like to really thank the Gold Foundation once again for allowing us to speak and meet with you all this evening. And thank you all for the work that you do to take care of your patients.
Here are some resources that will be available. And there is a PDF if you're interested. You can email us for that. And thank you again to the Gold Foundation, and I will stop sharing. And I see that there are already some awesome questions in the chat. So the first is, did the New York Times get permission to publish the pictures of people waiting outside? And I agree with Annabelle Andone, who said, I think it's likely because they were in public, they did not get consent. And I will tell you that when I was at that clinic, no one was getting consent for pictures that were being taken. I wasn't at that same clinic, but I was at the clinic. So I don't think so, but I can't confirm that. And so I don't want to say officially that they did not, but it is not my assumption that they did. Jess Rowland asked, do we have studies looking at trans youth who receive hormone blockers? And what about cis youth using hormone blockers for various reasons that we could extrapolate some of the long-term outcomes? So we don't have, what we use often in healthcare is large randomized controlled clinical trials. And we don't have those. because this is not a medication that's used so commonly, and also because there's not a drug company that's looking at it, so their studies would not be well funded. What we do know from the data is that for youth who are taking these hormones, the hormone blockers, ultimately, after a period of time, you let their endogenous, or the hormones that their body is producing, take over. They tend to be a little bit taller. They might be a little thinner or less muscular if they're having like less testosterone over time. Ultimately, they tend to do pretty well. There haven't been sort of significant impacts on bone, although there may be, but it's not really clear, and they seem to be fine. And no one is writing news articles about that we shouldn't be giving kids puberty blockers if we're trying to assess their height, which is also a social construction, right? Who needs to be tall? It's not a thing, but whatever, I'm not an adolescent medicine specialist. But what we know about adolescents who take hormone blockers so that they can avoid some of the symptoms of puberty is we know that they significantly decrease some of the dysphoria that people feel. You can imagine that if you were someone who was assigned female at birth, if you're 11 or 12 years old and start to have your period every month, and that's a reminder that your body is not consistent with your gender identity, that could lead to depression and suicidality. We have good studies that show that. And then the process from there is once the child is of the age of consent, or they have the consent of their parents, they can start using a hormone that is consistent with their gender identity. And that if they change their mind, which is what everyone seems very, very worried about, if they change their mind, then you can stop the blocker and the endogenous hormones will take over. Or if they have had a period of time on the blockers and their gender identity is consistent and persistent, which it often is, they can begin using hormones consistent with their gender identity. And so we do have some studies, they're just not huge, but it's certainly not the way it's being presented in the media. And what I see often in the media is these irreversible surgical changes that are being done to children, which is not part of the practice that we really engage in.
We are exactly at time, so please, please join me in thanking Christian and Richard for that very informative and very powerful presentation. As Katie said in the beginning, this will be available to all attendees as a video recording later. And we are back next month on December 14th for a roundtable discussion on the topic of diversity and equity in clinical trials, featuring Drs. Arthur Kaplan, Aisha Langford, David Oshinsky, and Julie Sowash. As always, CME will be available and it'll be free and open to all, so we hope to see you then. Thank you so much for joining us today, and have a really good night and great happy Thanksgiving.
Thank you, everyone.